I'm going to invite Kia Parker up here, who's going to present to us on pregnancy, SUD, and youth. So welcome, Kia.
Okay. Good morning, everyone. I'm very happy to be here. Sorry it's under these circumstances. But I just wanted to start off with a conversation I had. My daughter is a sophomore at Franklin High School. And as many of you are aware, there was a student who overdosed on fentanyl last year. And I had the opportunity to speak with one of her friends informally. And the bias I brought to that conversation was, you have to be so worried because fentanyl's out there and kids try one time and then they get this overdose with fentanyl because it's out there. And what her friend said was, no, this girl, and I'm not speaking about particulars, this is what I heard, this girl was using every day. She used with her parents. This is something that has been going on for a long time. And it reminded me, how sad is that people know that their classmates are using opioids every day and yet don't know how to make that bridge to stopping. And so this is kind of the theme of why I think we're here is, let's open up forms of communication. Let's talk about options. Let's do what we can to advocate for barriers to go down. Because unfortunately, a lot of my talk is going to be about what youth don't have access to. And that's the reality of where we are right now. And so our role is to continue to advocate for more avenues for youth to reach out and to get the support they need. So, our goal, we want to keep people alive. Folks with opioid use disorder, and I'm going to be talking a lot about opioid use disorder because that is the substance use disorder that right now is killing the most people. Stimulant use disorder is kind of right up there. But we have excellent medical management for opioid use disorder that works really, really well, and a lot of youth don't have access to it. Folks in recovery get better. And so that's something to keep in mind. And we're going to talk about, go through some cases that if folks with opioid use disorder, with substance use disorder, do not overdose, they get better and they go on to live productive, beautiful lives. And that is one of the joys of my job, is I'm following families who I saw perhaps at a nadir in their life when they were doing really poorly. And I get to see them 4 or 5 years later, raising beautiful families, having jobs, having their partners engage in care. And so I want you to keep that in mind, that folks do get better. We're going to review challenges. We're going to discuss resources that are available. And then I think it's important for our role is to continue to maintain positive regard. Like I said, as someone who sees families get better and sees families thrive, that's the lens I bring to every struggling patient. Nope, I know your future can be here. I think it's really hard for folks who, say my colleagues who work just in the emergency room, or folks who are working in corrections, who are only seeing one point in time at someone's low point, and it's hard to imagine, oh my gosh, I can't imagine that this is ever going to get better. It does, but we gotta be consistent. We gotta stick with our patients. So this is kind of part of what this whole talk is about. Most folks start when they're, most folks with addiction disorder start using when they're in their teen years. The opioid use in particular has changed. The type of patients who I'm seeing, that has changed. And I would have to say it has changed rapidly over the last 2-3 years. So, to put a break, pre-COVID, my typical patient who was entering into treatment for opioid use disorder would be started as a teenager, perhaps started using pills that either they had prescribed to themselves after a surgery or that they had a family member or a friend share with them, but it started with pills. Then it moved on to intermittent heroin use that would happen once a month. And then it moved on to daily heroin use. And then I'm seeing them around like in their 30s. And they're ready to stop using and they're ready to get into recovery and their brain has had time to fully develop. And that's where we started. It was like, all right, well, let's move forward. Fentanyl is different. And fentanyl is the first point of substance use that many youth are exposed to. And it has a rapid move from trying it to daily regular use. And so that's the difference. I mean, without being overly dramatic, like I gotta say, like fentanyl is dramatic. And I think we have to acknowledge what's going on. So here's, I know fentanyl now, they have it's called things like rainbows, Skittles. It comes in flavors. It's different colors. Like, items that are cheap and colorful. I mean, I like colors, I like flavors, but I'm not the target audience. So you have to think, who's the target audience for a pink pill that is watermelon flavored? And that costs less than a bag of Skittles. And so that is what's available. That's what we have to keep in mind. And here's some information about sort of like, let's think about this kind of statewide. So here we have a map, and this may change. This is sort of the most recent comparable data I was able to find. But here's a map of teen pregnancy rates. The darker color means higher. And so you're seeing, all right, these are the parts of our state that have higher rates of teen pregnancy. Now, this information was put together by Boulder Health. It's an organization that is offering substance use treatment remotely. It's a wonderful organization. I spoke with them yesterday and confirmed they still do not treat patients under 18. But this is information that they compiled that shows the darker, the color on the map shows the fewer providers who treat substance use per population. And you can see they match up pretty well. So when we're talking about substance use treatment for youth, we have to acknowledge that this is something that is predominantly not a Multnomah concern as much as it is in other parts of the state. Other things, we're working to expand services, but we have to keep this in mind. And when we're thinking about expanding services, we have to continue to reach out to communities, form partnerships with communities where, their population is affected the most. What is our first point of contact? Like I said, it's usually not a clinician. So pregnant patients with substance use, they'll present to care in a number of different contexts. Some present to the hospital in active labor. Some will present to their primary care clinic. Some will present to a pregnancy resource center or anti-abortion center. Some will present to Planned Parenthood. Some will present to a substance use treatment facility. And some will present to school-based health. The goal is to find out how can we disseminate accurate information, supportive information, non-judgmental information to the locations where folks are likely to present for care. It's not gonna work if we wait for them to come to us. So that's where we have to kind of reach out and say, all right, well, where are folks going to show up, and how can we integrate our services how can we partner with these places where folks are going to show up? Shout out to school-based health. This is the definition of decreasing barriers. So school-based health, that is a point of contact that youth are going to be aware of. They're not showing up to school because of the school-based health. Some people might, but they're coming in every day and they're seeing that, and they know this is somewhere I can go. They may have friends who have gone there, and they don't have to try to navigate wait lists. They don't have to try to navigate insurance. They don't have to try to navigate a ride. This is something they can do. And from there, you can get confidential services, you can get continuity of care. You're going to be able to branch off to abortion providers, prenatal providers, project nurture, primary care. So school-based health is huge, 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 huge. Now, some youth will present as their first point of contact for prenatal care. Now, it's important for all of our patients who are presenting to prenatal care to screen for substance use disorder. We're going to be talking probably further on today about the CRAFT interview, and here's just kind of an example of the CRAFT screening test. During the past 12 months, did you drink any alcohol? Did you use anything to get high? Did you smoke any marijuana? And then if there's yes to any of those, we go back. Have you ever been in a car with someone who is intoxicated? Have you ever used alcohol or drugs to relax? Do you ever use alcohol or drugs when you're by yourself? Do you ever forget things when you're using? Do you have family or friends? So this is something that's a helpful conversation starter. The other thing I like to just incorporate when I'm meeting any patient for the first time is open-ended statements such as, many of my patients have experience with drug use or substance use, such as fentanyl. I have a lot of folks who have a hard time stopping this. If you or someone you know is having a hard time with this, please let me know, because we have a lot of experience. And so that's not saying, oh, you look like someone who's using, and I think, you should probably, because you're wearing thick eyeliner, you probably are doing drugs. It's not saying that. It's saying the reality of the situation is there's a lot of folks out there who are struggling with fentanyl right now, and there's treatment options. You might not know that the person you're talking to right now is aware of treatment options. You might not know that people ever stop using. You might have heard that your friends who are using have tried to stop and it hasn't worked, that their parents or their family members or their friends have been using for decades and have never been able to stop. And they might not ever know anyone in their life who has stopped. There are more individuals who have a personal relationship with someone who has died of fentanyl right now that I'm coming in contact with than folks who don't. And so open-ended statements like this, I've had experience where I've, kind of just mentioned this, done prenatal care, and then 8 months later, had a patient come back saying, remember when you mentioned that? Well, actually, my partner and I really thought we could do this on our own, and we're struggling. And great, we're here. So consistent messaging, universal positive regard, stay focused on the happily ever after. Folks who are in recovery do wonderful. They go on to do wonderful, beautiful things. So keep that first and foremost in your mind. Engaging support people. That's going to be really important. And then remind patients that in Oregon, abortion access is available across the board. And so that is something that is something that it can be confusing especially with someone who's kind of hearing different things. And, there's a lot of misinformation out there, especially kind of depending on their first point of contact. But again, you're not making a decision on behalf of this individual. I have a lot of teen and youth patients who their pregnancy is, all of my teen and youth patients who have been pregnant, their pregnancy is desired, is wanted. And so I want to be mindful of, it's important that folks are aware of options, and also important that to acknowledge that, and there may be kind of societal reasons, gosh, why would you want to be pregnant at 17? And it may be, I don't know any other option, or this is the only thing I can think of that's going to bring meaning to my life. But in that moment, making sure that patients know that there are options, and then continue to support them with the decision that they make. And then offer Narcan to everyone. We need to just have Narcan out. It's covered by a lot of insurances. It's easily covered by OHP. Narcan is available without a prescription. You can get it from outside in, but it's not as readily available as I wish it were. I think one of the nurses I work with, she says she was at a bus stop recently, and she passed someone who was slumped over, and she said, "Do you need Narcan?" Just as a first step, which often someone will be able to say. If someone can verbalize, "No, thank you, I do not need Narcan," that's a good sign that they don't need Narcan. And she was impressed that 3 other people at the bus stop pulled out their Narcan. And so that's good to know. I keep mine with me. And so it's just something like, wouldn't you feel bad if you didn't have it available? So I try to get Narcan into everyone's hands. I put it in my kid's backpack at school, reminding folks, especially youth, that it's not cheap, and it's not readily available. I wish it were as readily available as a basket of condoms or something, but it's not. If you're buying it without a prescription, it's about $10, $15 per dose. But also reminding folks that this is in the event that you Narcan someone accidentally, they were having a heart attack and I gave them Narcan, that's okay. You're not gonna mess up with anything. It's but you have the possibility of saving someone's life. That's something that I think is really important messaging when we're talking about having Narcan available in public spaces, like libraries and schools, is you don't need to worry about this. This isn't a medicine that's gonna have side effects that are gonna be dangerous. This is a medicine that might save someone's life. Now, sometimes folks present for substance use treatment as a first step. And if that's happening, you want to screen for pregnancy. You also want to screen for other things. And this is where we're going to be talking about our healthcare system is set up in a siloed manner that can be challenging to navigate. But any point of contact, try to get the big points touched, because you might not see this patient again for months and months. Screen for intimate partner violence, review options to find out more about that. Screen for STIs, screen for safe living environment, and offer Narcan. Just keep in mind the holistic approach to medical care with every point of contact. There's a lot of challenges in engaging in treatment for substance use disorder. I would say the majority of patients, and this is more common in younger patients, don't see a need to engage in treatment and have a sense of, no, I'm different. I don't use that much. I can stop anytime. And that is something that I hear a lot. And I see, I do a lot of work with folks who are pregnant and have substance use disorder. And I hear over and over, I knew that I could stop before baby came, and then baby came. And we meet patients where they are, but the sense of, oh no, I can do this, I can do this, I can do this is really strong. Methadone clinics, and we're gonna go into this a little bit more later. Methadone clinics don't treat patients under 18. Methadone is a easier medicine with fentanyl, and that's where we are. But if you're under 18, you can't get methadone. Many patients don't identify with a primary care physician, and I would say I have a partnership with CODA, and we certainly don't see patients under 18. And I would say of our patients, probably around, 80+% do not have a primary care physician. And their point of medical care is through the methadone clinic. Obstetricians, if someone's presenting to an obstetrician, their training typically does not include treatment for substance use. That's not always the case, but typically that's something that is not included in routine obstetric care. Pediatricians often don't manage pregnant patients, and they rarely treat substance use disorder. Addiction doctors often are trained, kind of come in addiction doctor. I'm a family medicine doctor, and so also treat youth, but many addiction doctors are trained in internal medicine, and their focus is on over 18 adults. So many communities out there, particularly in, when we had the map up of the areas that have higher rates of teen pregnancy and lower proportion of addiction medicine providers, many of those communities make it challenging for family medicine physicians to treat patients who are pregnant. And that has to do with malpractice insurance. It has to do with surgical backup and hospital privileging. It has to do with a lot of things. But keeping all those things in mind is important. When a patient shows up, often they don't show up alone. So if you have a young patient who's showing up either for substance use treatment or for prenatal care, often, and thank goodness, often they are not showing up alone. So they'll be showing up with a family member, with a friend, with a partner, with a parole officer, with a DHS representative. Regardless of who they're showing up with, acknowledge that likely that person has a bigger impact, for better or for worse, bigger impact on your patient's life than you do. Engage with support people and educate support people. Thank them for coming in. Support is infinitely better than no support. And I acknowledge there's some support that's preferable to other types of support. However, it's important to engage in the folks that are important for a patient's life. So here's a quote that one of my patients who delivered about a month ago came in with her mother, and the mother said, so the grandmother of the baby, "My daughter is a hardcore addict. Everyone in our family is. I'm a fourth generation addict." And that's hard to hear from someone who is your support person. And also, you have to acknowledge, again, this is neither good nor bad. This is what it is. This is the support person for our patients. Let's work with this family. Let's engage this family, and let's move forward. And ultimately, we actually know that there's a lot of intergenerational trauma, and we know that there's genetic factors and environmental factors that make it more common for substance use to be found in families. Our hope is to intercept some of that kind of intergenerational trauma. But sometimes you hear these kind of things and your first response is, oh gosh, that doesn't sound like supportive. And writing it off is not gonna improve your relationship with anyone. And so you have to acknowledge the person who said this, my patient's mother, my patient loves this person more than anyone in the world. And how can we sort of use that relationship and move forward with that relationship and focus on recovery and focus on how well folks are doing and focus on kind of the bond for the child and the mother, and kind of come out with a better outcome. So this work is really hard. In case I made it look easy with our earlier slides, but this work is really hard. However, respectful, consistent engagement can have a lasting impact. I'm gonna go over a couple cases. The cases that I'm presenting are in young patients, but they are over 18, and that's because those are the patients that I'm seeing. So a 19-year-old first-time mom first-time pregnant patient presents at 30 weeks gestation to CODA, which is an OTP or methadone clinic, with her parole officer. We had an initial visit, and then following that, there was poor engagement in methadone management, no further prenatal care, and syphilis that was diagnosed at the initial visit, or it had been re-diagnosed at the initial visit and hadn't been treated. So this patient presents to the hospital in active labor. One thing to acknowledge is pregnant patients, it is a segment of the population that you will be able to talk to. They will have contact with the medical establishment almost always, and using that as an opportunity to educate and engage, even if someone's just showing up for the first time when they're having a baby, using that as an opportunity to educate and engage can make a big difference in this family's life, and then also the folks that they talk to. They might be able to say, oh gosh, I have friends who are doing 2 months. They haven't done any prenatal care, but I met someone that wasn't as scary as I thought it was at this hospital. I'm gonna send my friend to you to talk about this. And so that's what you're looking for. This particular patient support person, identified as her pimp by the parole officer, is a 58-year-old man who has 13 other children. Shortly following delivery, this patient goes into withdrawal. With fentanyl, the withdrawal comes it's a powerful withdrawal. It's powerful, and it leads folks to do things that they wouldn't otherwise do. So this patient was able to be stabilized on methadone while in the hospital. There was concern for ongoing fentanyl use while she was admitted in the hospital. I just want to put out there, most folks do. So most folks, you hear this and you think, oh my God, someone's using fentanyl in the hospital. Like, whoa, most of our patients now. And so the conversations I'm having with folks when we're trying to bring them into the hospital to transition from fentanyl to methadone is, I have that open conversation, is for a lot of folks, it's really hard to make this transition. Please let us know what we can do. If you're having cravings, if you're kind of feeling like you need to leave the hospital to go use, please let us know, because we have access to medications. The reality is we are just now trying to figure out how to completely address fentanyl. And most of the time, I would say 100% of the time in my experience, we've been under aggressive. We haven't been aggressive enough with medication-assisted therapy for folks with fentanyl use disorder in those kind of initial days. So DHS, we want DHS, we work with DHS, we want DHS to be an ally. Our goals are the same: safety of families, so 100%. And I do not envy the challenges of that DHS is faced with. I do not envy that at all. In this particular case, this patient and her baby were placed with a paternal grandmother who's in her 80s and has multiple medical concerns. I would call to try to get hold of this patient for newborn care. And the great grandmother, so the grandmother would say, I haven't seen this family in days, and I'm at risk of losing my housing if she stays here. And you think, whoa, wait, why was this the safety plan? And also I want to be very mindful that this wasn't the story that was relayed. And when you're trying to come up with a safety plan in a matter of hours, you do what you can do. And so I want to acknowledge that all of us are allies, and we're all trying the best we can with the available information, and also point out that often safety plans aren't so safe. And so, kind of re-engaging how does this look? And okay, what do you think about this? Okay, how are we going to move forward? That's an ongoing conversation. So it was hard to get hold of patient for newborn care. This baby eventually was removed from mother's custody and is living with maternal grandmother at this time, who is bringing baby continually on for care with our clinic. So we have maintained continuity in that regard. The other point of this is we're still there. So they're in touch. They're in touch in a way that we're not in touch, but we're always here. So during relapses happen, and you want to know that relapses happen, and it's something that we expect, and we will always be here. You come back, great. We're here for you. We're here for you. And grandmother, I want to make sure that you have Narcan, because you're going to be in touch with folks who may need it. And so maintaining that, asking for patience, because this isn't a character flaw. This is a sign of an illness that needs support. And just like, someone who has diabetes or depression, they don't show up for a while. It doesn't mean that when they show back up, we're going to scold them. It's okay, you're here. Let's take these next steps. So treatment options for opioid use disorder. Cross this out. Yay. Okay, so methadone. Methadone is easier to start. Methadone, I have to say, I don't know if you agree, but I feel like it has improved patient adherence with fentanyl. You do not need to go through withdrawal when you start methadone. Part of that does involve often, like I said, ongoing fentanyl use while someone is bringing up their methadone dose. And that is something just to be aware of and to acknowledge, and you don't want it to happen, but that is something that happens. So be aware of that. Continue to talk about harm reduction strategies while someone is getting to what I refer to as a holding dose. For pregnant patients, we have the opportunity to admit them to the hospital. And if you're gonna get too much methadone, the best place to get too much methadone is in the hospital. And I've never seen someone get too much methadone, and we're going up pretty quickly in the hospital. For patients who are not pregnant, who do not have another medical reason to be in the hospital, insurance won't pay for a hospital admission. We're working with programs to make it more available for detox facilities because if you don't have any other medical concerns, you don't necessarily need to be in the hospital. In the hospital, I have to say, I get paid to be in the hospital, and it's still not my favorite place. So for a lot of folks, this brings up trauma. This is stressful. This is not somewhere where they want to go. But for pregnant patients, we can use that, and we can get them to 150 over a matter of days as opposed to weeks to months. Buprenorphine, it's not impossible. But I do want to acknowledge it's challenging to start for folks who are using regular fentanyl. There's a lot of different approaches that are being tried, and so that's one thing that's really exciting about working in in addiction medicine is there is creativity of it, and then there is no patients are the same, and a patient with diabetes, you can say, here's the guidelines. You do X, Y, and Z in that order, and you expect these outcomes. With patients with substance use, particularly opioid use disorder, it's much more nuanced, and you have to be able to kind of work with the patient and figure out, all right, what's gonna be best for this patient. Detox facilities, unless I'm mistaken, most of the detox facilities, so inpatient detox facilities like Fora and Hooper are not available to folks under 18. Like I said, we can transition. Buprenorphine is readily available. It's easier to find buprenorphine for folks who are under 18. It's easier to find buprenorphine for folks who live remote from a methadone clinic. And so that is something that there is the possibility of telehealth with buprenorphine. And so when we're thinking of communities that have that are affected with teen pregnancies and with substance use disproportionate to, per population disproportionate to other communities, buprenorphine definitely could be the saving grace in those communities. And also, I want to acknowledge buprenorphine is a better medicine. I'm having a lot of patients, now that we saw how hard it was to get fentanyl to buprenorphine, we used to think it was almost never you would transition someone from methadone to buprenorphine. Methadone to buprenorphine is way easier than anything with fentanyl. And so letting folks know that methadone is not necessarily forever. Methadone is a life-saving medication. I'm so glad it's available. And for some folks, they do really well transitioning from methadone onto buprenorphine, and that's something that we can support as well. Okay, so let's see. Here's another case example. So this is a 19-year-old who did not have any prenatal care. She presented to the hospital after she had an unattended home birth 2 weeks before. And in this particular case, she planned it this way. This was not accidental. She was in touch with someone who was known as Dr. Barbie, who was not a midwife or a physician, but was able to administer substances while she was having her baby. And then when this patient's mother found out that her daughter was no longer pregnant, she brought her to the hospital and she engaged in care that way. While she was in the hospital, she actually initiated treatment with buprenorphine. That slide's incorrect. So she she was actually on a really small dose of buprenorphine. So she stabilized on a small dose of buprenorphine while in the hospital and was very adamant about this is a perfect dose. Everything's going great. This is wonderful. Everything's good. She discharged to stay with her mother and her father, and who offered 24-hour supervision per DHS requirement. But she continued to use fentanyl. And she had buprenorphine was directly monitored. And I think her dose that she said was working for her was like 2 milligrams. Fentanyl's still gonna work with that dose. And so this is an example of you have to acknowledge that the quote I gave earlier about a mother who had been, like this, the mother who said, oh, my daughter's a hardcore addict, but the mother who said, everyone in my family is, I know this. You're like, whoa, that sounds not great. In this case, parents had no experience with substance use, and that's hard too. And so this patient, after ongoing continual fentanyl use, ended up moving from her parents' house. And she was, her parents had a very comfortable home, but she moved into a residential facility. She transitioned to methadone, which was a better fit for her, it turned out. After that, she moved into her own apartment, and I have to say their insurance has changed, so we haven't had ongoing contact with this family. But there's a lot of shame in use. There's a lot of risk with using in the context that your whole world might crumble if you're caught. And so when I'm talking to patients and their support people have no experience with substance use, either personally or familiar or anything like that, I'm not always relieved. That's not a surefire like, oh, great, I'm so glad you found someone who's not gonna use drugs. So I talk about this hotline and never use alone. I think it's very important to share with our young patients. And we think of youth and substances as being something social, like, oh, kids go to a party and they, do drugs, or they're sharing stuff, with their friends and they're all together. With fentanyl, we're not seeing it so much like that. So consider the isolation, and if you may have started off by using socially, but if now you're moving to, I'm really sick if I don't use, that's when you're seeing more use alone. And everyone in your life can have Narcan, but if you're using alone, that's not gonna help. The Never Use Alone hotline, I mentioned it to one of my patients. Our nurse, maternity nurse who does prenatal intake, mentioned it. This patient got hospitalized. She met with our inpatient addiction team. They mentioned it. I came on service and I mentioned it again. And that was, kind of 4 contacts. After her hospital discharge, she came to me and said, I heard about this number so many times that I actually, when I relapsed, I called it. I kept thinking it was gonna be weird or awkward. It's like, it wasn't weird. It felt comforting. And now she's really doing great in her recovery. So I think everyone in this room sort of understands that having a phone number that's, that will, if you, so this is, you can chat with them if that's what you'd like to do. It's not someone who's gonna give you resources to stop using. It's only someone who's like, well, I'm gonna just check in on you every so often, and if I don't hear from you, I'll call someone to come in and check in on you. And so it's that type of resource. And so she found it very comforting. And I think what we've seen before is when you offer support, when you focus on the value of human life. Like, this is what we're saying, is like, your life is valuable and I don't want you to overdose on your own. That doesn't encourage more use. When there's shame involved, when there's like, I'm so nervous that if I get caught, my baby's gonna get taken away, or I'm gonna lose my marriage, or I'm gonna get kicked out of my parents' home, that stress doesn't lead to folks using less. That stress increases use, and it increases use in more risky ways. I've had a lot of patients who are muscling in locations that lead to really bad abscesses because they don't want to have track marks available to be seen by their husband, who they'll say, oh no, my husband doesn't know I use, has never used. If he saw this, my life would be destroyed. So this is important. All right, this is, final case. So this is a 20-year-old patient, and this just highlights that as a mother of 2 teenagers, it sure would be convenient if all teenagers were the same, but they're not. And so meeting patients where they are and acknowledging that, like, everyone's life is different. This is patient presented to CODA for methadone treatment, established prenatal care at about halfway during her pregnancy with Project Nurture. Following delivery, she entered residential therapy. Her husband also entered residential therapy at the same time. 6 months postpartum, she has stable housing. She's doing well in her recovery. Her partner's still in residential. He's training to be a peer support person. 10 months postpartum, she's transitioned from methadone to buprenorphine. That transition went really well. She's an active participant in our Project Nurture group. She babysits other kids. She's encouraging support. And right now she has an upcoming interview with 4D to be a peer recovery mentor. And this is in the course of a year. How cool. And so this is wonderful, and I hope that y'all get an opportunity to meet this patient, because she really is a testament of like, oh, how far you can come. So residential treatment is really, really effective. I like for my patients to have as smooth of a transition from getting on a holding dose of their medication to residential as possible. Hopefully some of this is outdated, but when I last checked, Fora Detox and Hooper Detox aren't accepting patients under 18. NARA Youth, they have inpatient and outpatient services. This is from conversations, and these are the phone numbers that I reached out to. They heavily encourage substance-free recovery, but I was told they rarely support buprenorphine. This all might be changing. Fentanyl is, we're still on the West Coast. We're at we're not seeing as much fentanyl and as many deaths as they're seeing on the East Coast. And so we're doing like on a United States level, we're doing great. And I think it's just because we're only now starting to see patients inject fentanyl, and that's coming. And we're only now starting to get kind of xylazine or trink in our fentanyl supply. And there's no reason to think that we're special. It's gonna go backwards, here. So my thought is we're gonna be moving more. And so I do think that our programs are gonna be adjusting their policies, just like Circle Recovery, adjusting their policies to take into consideration the nature of this epidemic. So Madrona Recovery, this is in Tigard. They serve youth 13 to 17. They prefer youth to taper off Suboxone, but they said they would be willing to continue it. They would be okay to take a pregnant patient. It's a short-term stability program. And then Deer Creek in Roseburg is kind of far away, but they serve youth 13 to 17. They'll see patients on buprenorphine. They'll see pregnant patients, and their medical director says they don't usually start medication-assisted therapy, but they will continue it, and they want to be in close contact with the primary care team. Deer Creek does, if this comes up, they do take statewide OHP. One thing that's challenging, they'll say, is even though they accept any flavor of OHP, if the patient also needs, for example, a dentist, and they're from, Astoria, then the dental coverage isn't gonna be transitioned. And so they're like, oh, it's just too bad, because wouldn't it be wonderful, wow, these kids are in recovery, that they're also getting their dental needs met, all of that. So Daybreak Youth Services, that's in Vancouver, they're not available. So MAT, that's buprenorphine, that's methadone, it can reduce overdose deaths by 50%. It would be like, it's so important. It's like when you have a heart attack, we give medicines for a heart attack that keep you alive. When you have opioid use disorder, we give medicines for opioid use disorder that keep you alive. It's very important. However, only 25%, and I think this was alluded to earlier. So this is only 24% of adolescent treatment facilities offer buprenorphine. And that's kind of what we're seeing too. Project Nurture, I'm gonna just briefly give a shout out to Project Nurture. We have Project Nurture sites at all the major hospitals. We focus on prenatal, postpartum, for those that have family medicine doctors. We also do pediatric integrated with substance use treatment. And so all sites have experience working with young patients. And we see a lot of challenges, we see a lot of successes. I also want to just put a shout out to my favorite type of medicine, family medicine. So as family physicians, we're trained in pediatrics, we're trained in adults, we're trained in pregnancy, we're trained in substance use, we're trained in psych. We're not a specialist in any one of those things, but we're not afraid to see them because we have that training. And so whereas someone whose entire medical training has just focused on non-pregnant adults, if they see a pregnant 16-year-old, that's not part of their training. And so, that's something, if you're looking for, oh my gosh, here's this patient in rural Oregon, I don't know where to start. Think about family medicine as a first place to start. I've seen a lot of sort of nationwide movements to, one of my neighbors works for the CDC and he's a pediatrician, and he did a big presentation for, we need to train pediatricians to recognize and treat substance use in their patients' parents. And I was like, whoa, that's a big ask. And I mean, it's like asking me to, also fix your car. And I'm like, I'm just not trained in that. And so that is, I'm not comparing cars, and that is because across the United States, we have a move to silo healthcare and to focus healthcare into specialists. And specialists make more money doing this. There's in Kentucky, there's a policy that says if you're pregnant with substance use disorder, you can only receive treatment by a perinatologist. So that's a high-risk pregnancy doctor. And I grew up in Kentucky. There's like 4 of them. And you're thinking, oh my gosh, like talk about decreased care. So we can kind of talk about questions. Any other thoughts, comments? Good news.
Thank you. This was fantastic. And I appreciate the shout out for family medicine because I'm a family doc myself. I'm also the medical director for the residential program at FORA, so I can give an update on that. So we currently still cannot take folks under 18 for any of our services, withdrawal management or res. We are looking at that. It's hard. We used to have a residential program for youth, and we just couldn't get the reimbursement, honestly. So that's something for our payers to think about. But in our residential program for folks who are over 18, we have a specialized program if they're pregnant and need kind of any level of care. So if you have folks early in pregnancy, so it's really first 2 trimesters, 3rd trimester, I would suggest sending them to Lady Owings or Lifeline Connections, because they're really going to do the pregnant and parenting work with them around their delivery. But if it's in the first 2 trimesters, we would love to have them. And we do have a specialized program to provide support.
Yay. I love all this good news. Woo. Thank you for the work you do. Fora's amazing. And I think we've chatted on the phone a lot.
So I have a comment and a question right here. Sorry. So first, just with Multnomah County Primary Care Clinics, we can offer MSR and MAT for 15 and older. And we can consider younger depending on the circumstances.
Great. Buprenorphine, are you a methadone clinic?
No, we're not a methadone
No,
clinic.
okay. Buprenorphine,
Yeah.
yay.
Thank you
Awesome,
for
wonderful.
clarifying. I guess my question is, how do you navigate, and being very, very knowledgeable, but maybe other entities that you work with or individuals that you work with, how do you navigate sort of the misinformation and just the complexity of involving parents or DHS or mandatory reporting and all that stuff?
Yeah. And so it's tricky, and the involving. I mean, if you're over 18, you don't have to involve parents. I mean, I don't want to speak on the laws, but I don't believe you have to involve parents if they're over 15. Am I speaking correctly? And under that age and also over that age, often I prefer, and I'll have a conversation. I mean, my routine adolescent visit is, okay, I have, whoever the support person is, in the room. And then I'll say, all right, now this is the point where I ask parents to step aside and we have a conversation. And most of the time, this is again, like, what patients are we seeing? Most of the time, patients are there with their parent. Most of the time, they're not sharing something with me that they haven't already shared with their parent. So I have to say, the vast majority of the time, it doesn't come up. And when it does, and that's, I mean, when it does, then that's where you do have to think, okay, let's come up with a plan and let's involve our behavioral health and let's talk about this. And again, in my experience, it always does involve bringing the parents back in. Now, with DHS, substance use alone is not a reason to involve DHS. And so for parents who, substance use alone is not a reason to involve DHS. For patients who are using with their parents, is involving DHS, you have to think, like, is involving DHS going to help or hurt the whole situation? My approach tends to be more engage, and let's talk about this. Let's get everyone involved in care. And but it's not easy. And then DHS, I reserve, and I when I'm talking about DHS, I will call DHS after I have a conversation with a parent. And so I haven't had a reason to call DHS on someone without involving the parent, but it's super tricky. And then you worry about, like, this safety of the kids and different things. So I don't know. If anyone else has an easy answer, I'd appreciate it.
I think I missed the part where you explained why communities make family medicine physicians difficult to care for pregnant patients. Can you please repeat that?
Yeah, for sure. And so it's part of it is in different communities. Like, so if there's a community that has one obstetrician who's been doing all the deliveries forever, and there's not that many babies getting born in a rural community, and then there's a family medicine doctor who says, oh, I want to do like 3 deliveries a year, but I'm not doing enough deliveries to actually be able to do C-section if necessary. So I'd like you to be available in case I need like a surgery. And then, the obstetrician's like, no, I'm not going to be waiting for you. And so I'm not, I could see their side. So that happens. In addition, if you're, and this is more of an issue outside of the state of Oregon, but I trained in Miami, Florida, where the risk of being sued if you were taking care of pregnant patients was so high, and this was, 15 years ago, that the cost of malpractice insurance, if you were gonna be taking care of pregnant patients, was $250,000 a year. No family doctors are making that much money. And so they're like, wait, I can't go into debt just to pay for malpractice just so I can take so there's those types of and some of it is lifestyle choices where family doctors are like, I'm not doing it that much. I love it. I see this as a piece of primary care that is an access to essentially healthy patients. And so that's, and then you're like, oh, wait, let's talk about smoking cessation. Because, if you look at cis male patients, no one's showing up to the doctor in their 20s. And cis or pregnant patients, they're showing up because they're pregnant. And I'm like, oh, great. Now we can talk about this. Now we can actually get your partner in for care. Now we can, and then we can branch out. So I love that part of my job, but I also understand some folks like to sleep at night. Yeah. Oh, for sure. Any other thoughts? Okay, well, thank you so much. This was truly a joy to be here.